Hello Instafam, it's Dr.T here for our rapid fire Q&A on a Tuesday night. How are you guys? I hope you're doing really well. I have had a really good day. And I've got to share with you that I was getting ready this morning and my husband returned from his swimming training, walked in with his massive bunch of flowers. Happy Valentine's Day. And I'm like, where did you get those at 6 a.m. in the morning? And he said, they've been in the laundry sink. I knew you wouldn't go in there. So I'm kind of pleased that I got the flowers, but there was this realization that, yes, you're right. I don't actually go in the laundry very much. Anyway, happy Valentine's Day to you, wherever you are in Australia or the world. I hope you had a lovely day and somebody in your world treated you like a special individual that you are. Okay, so guys, as you know, you have the ability to drop any questions into the comments here. Please try not to give us your life history. Try to make it as generic a question as possible, and I will give you as generic an answer as possible. That is going to be helpful for many. Please don't hesitate to jump in with your questions. All questions are great questions, and I can promise you there's going to be somebody else on here who will really benefit from the answer. But while I'm waiting, while everyone's jumping on, hello, Michelle Arnold, good to see you, Mia Comedi, Big Mum Plum, Jazz, these are great handles, guys. Caitlin, Drama, Becca, Luke Smithy. Good to see you guys on. Good to see you on. Hey, Brookie, thanks for jumping on. All right, I want to tell you a little bit about sperm. Don't you love that? I always laugh when I talk about sperm. Does anyone else do the same? I want to talk about sperm because I have had lots of discussions today with patient couples around sperm. And I don't know if you know this, but I want to shed some light on a couple of things. I love this book here because it gives people a really good idea of normal and abnormal sperm. So sperm essentially, I mean, it's a pretty important cell, but it consists of a head, a midpiece, and a tail. And sperm need to swim, so we need to assess their progressive motility. There need to be enough of them, so we look at how many or their concentration. But the other thing that's really important is the morphology, right? These ones here, they're all abnormal in some way. Either the head's abnormal, the midpiece is abnormal, and the tail is abnormal. And these are the normal ones. So here's the amazing thing. When we're doing a semen analysis, one of our scientists, or using a computer analysis system, is actually assessing all of those parameters. How many they've got, do they move forward, and do enough of them move forward progressively, and what do they look like? What does their morphology look like? And there's some other things that we look at as well, but they are the main things that we assess according to the World Health Organization cutoffs, thresholds. So how do we determine those? Well, there are about 10,000 men that they looked, and they looked at fertility over a 12-month period of time, and they looked at fertile men, so men who fathered a pregnancy, and they looked at the lowest fifth centile of those values in those men. And that's the cutoff that we use to assess whether someone has a fertile semen analysis result or an infertile semen analysis result. And so one of the things we look at is morphology. Here's the kicker. A man can have 96% of his sperm as abnormal and only 4% as normal, and that is considered to be a normally fertile semen analysis. Because he has so many millions of them, he can afford to have lots of abnormal ones. What is the importance of sperm morphology? Is it an important parameter? Well, there's a lot of conjecture about this because unless a semen analysis is assessed and 100%, as that scientist is looking at all the sperm and counting them and looking at how they look under the microscope, unless you have 100% sperm looking abnormal, there's probably a good chance that person can still conceive, right? The other thing it's very dependent on is the scientist judging what is normal and what is considered to be abnormal. So it's somewhat of a subjective measure. So it is one of those parameters we probably in research and in practice, we don't pay as much attention to as how many have you got and how well do they move. They're probably the two more important parameters, and morphology probably isn't as important as the other two measures. So what do we do when we get a fella who has a persistently low morphology? Let's call it 1%. What do we do if we have a guy who has only 1% of his sperm that look normal and 99% of his sperm look like this? Well, the thing is, we don't actually really know, because it is still possible that spontaneous conception can actually occur. However, the chances are going to be much, much lower, because the sperm that finally makes it to the egg might look a bit abnormal and therefore might not be able to fertilize the egg. And that's the problem. So many clinics will revert to doing IVF with ICSI, where you take one normal looking sperm that moves forward in a progressive fashion and inject that into the egg. But obviously that requires the woman to go through stimulation and egg collection. So it's a pretty big deal. Where is the cutoff where we would consider moving forward with ICSI treatment? Well, the jury's out. When we, as a CREI group, have looked at the international literature, there is really no good, strong comment on exactly what percentage of abnormal sperm we're willing to accept to do IVF. Many opinions around the world in laboratories. Some scientists say, look, if they've got 1% normal morphology, we'll probably do ICSI. If they've got 2% normal morphology, we'll probably do ICSI. 3%, well, you're pretty close to normal. You could probably get away with doing IVF. And then 4% is considered normal. I think most laboratories around the world would suggest that if a man has an abnormal morphology level, meaning 4%, less than 4%, they would probably be encouraged to do IVF over, IUI, or encouraged to do that as opposed to pushing on with spontaneous conception because of that lower probability of conceiving. But morphology is definitely one of those parameters that there is not good, robust science around with regards to what is the right treatment to move forward with. As far as how can we improve morphology, it's thought to be inherent. So the simple answer is we don't know. We don't know if there's something in lifestyle that you can do to improve morphology, or if there's something in lifestyle that has affected negatively the morphology. Generally speaking, it is something that is inherent in the man, and no amount of lifestyle changes, supplements or stopping drinking alcohol and so on is actually going to change morphology. It certainly will change other things such as DNA fragmentation and oxidative stress, but it won't change morphology. So I thought that might be a little bit interesting for you. Over the month of March, I'm going to sort of post some sperm images for you guys to have a look at, because they're always really interesting. Sperm is really interesting. Now, I still haven't had anyone drop any questions. What's going on? Tuesday night, rapid fire Q&A and no questions. I didn't actually have a chance to see if anyone had dropped anything via DM to me. So if you have DM'd me, it hasn't made it up here. So don't hesitate to repop that question in the comment section. But it's good to have you guys on. Lovely to see you. Michaela Pike, I hope you're doing really, really well. Chloe Mack, Naomi Sutton, hope you're doing good. Carla Thomas, lovely to have you on. Michelle Duffy, lovely to see you. Oh, guys, awesome to have you guys on. Any questions? This is your chance. Rapid fire Q&A. Drop it in the comment section. Otherwise, there's going to be crickets. I'm not very good at this small talk. I filled in at least 10 minutes talking about sperm. Oh, I'm glad you enjoyed that, Michelle. Thank you. Let us talk nutrition. Nice handle. I quite like that. Kiara Crotty, thanks for jumping on. Good to see you. Thoughts on BMI cutoff in IVF clinics? Oh, it is rather a contentious one, isn't it? And there are lots of opinions around the world and around Australia. The first thing I'll say is, I'm about to sneeze, excuse me. The first thing about a BMI cutoff is that it is a guideline, right? So some clinics require cutoffs for their surgical procedures. Perhaps they may have a freestanding day surgery, and there are BMI cutoffs from the point of view of the safety of the surgery, right? So that's a hard and fast. But as far as would you treat a woman with a high BMI? Well, the first thing is BMI, I guess, is our surrogate measure that is used in medical fraternity for a measure of overweight or obesity. It is a guideline. It's not a hard and fast. Most clinics will have a BMI cutoff of 35. Why is this so? Well, there is some research around the impact of overweight and obesity on egg quality, on embryo quality, on endometrial receptivity, and probably most importantly, on your ability to respond to the medication, our ability to do optimal treatment, so actually get you the result that you're after. And then we as fertility specialists have an obligation to the well-being of a future child. And we do know that overweight and obesity in pregnancy can increase the risks of things like preeclampsia, gestational diabetes, preterm birth, cesarean delivery, nursery admissions, which then increases comorbidities in the baby. So the baby having effects, things like cerebral palsy rates, and so on and so on. So it is a health condition that we would like to manage to get you the result that you're looking for. And the result that you're looking for is a happy, healthy baby, right? That's what you want. So we want to make sure you get that in the safest and most effective way. And we know that overweight and obesity can impact on those things. Now, is that a moving thing? Absolutely, it's a moving thing. And I strongly believe that sitting down with your fertility specialist and talking about your individual scenario, how old are you? How many eggs do you have left? How much time might you be able to commit to losing a little bit of the body weight? What are the methods that you've tried? Are there ways that we can actually help you achieve those things? And that's actually part of your fertility treatment. So I think as a fertility specialist, it is our obligation to have that chat with you and start you on that fertility management process, which could be actually shedding a little bit of weight. So I'm really hoping, Kiara, that has helped at least, frame it for you. And I think your fertility treatment starts at that point. And it certainly does with all of me, with me and the discussions I have with my patients. So great question. Thanks for dropping it in there. Michelle Arnold, what are the chances of successful implantation if you bleed during transfer? Oh, that's such a great question. Okay, so I guess one of the things that we do get concerned about is bleeding at transfer. There's not a lot of great data, but we do know that the poor quality data that is out there suggests that if you have blood on a transfer catheter, then there is the suggestion of interruption of the endometrium and a poor implantation rate. However, how is that measured? And who's measuring it? And are they measuring it on the outer catheter, or are they measuring it on the inner catheter? Or is it that they're measuring it as you reporting, oh, I had blood on a pad after having had a transfer? So interpretation of the data, I think, is wanting. But there is guidelines that we look at with regards to optimal transfer, and one of the things that is probably a less optimal thing to find is someone who has had bleeding after a transfer probably due to trauma of one part of the reproductive tract. Now, if you get bleeding from, say, a cervical ectropion that's a little bit fragile when you touch it, so the ectropion is where those canal cells evert onto the outer aspect of the cervix, probably has no impact. But it's the bleeding from the endometrium and the cavity that we care about most. Good question. Akitane. Sorry, I probably said that wrong. How to improve cell division in embryos, struggling to get past 8 cells. Yeah, there is not a lot that you can do to change that. Embryos that fall over at day 3, so cleavage stage, day 3 is when you're getting about 8 cells. But embryos that arrest after getting to cleavage stage, generally that's an embryo quality issue, because it's about day 3, cleavage stage, when the embryonic genome itself really kicks into play and it becomes its own entity. It's not reliant on the internal structures of the egg anymore, or the energy producing aspects of the egg. So I would absolutely be sitting down with your fertility specialist and embryologist and really examining your embryos and having a good chat about that. It is devastating. I am so with you. Okay. All right. Oh, Kiara's asked another question. This in the context of PCOS? Yes. It's one of the hardest conditions, PCOS, to manage. In fact, here's the thing. If you took a woman who had PCOS versus another woman who doesn't have PCOS, and they're both the same weight on the scales, the woman with PCOS will have a higher fat mass. So the proportion of their body that has fat will be higher than the same weight woman who doesn't have PCOS. Why? Because it's part of the syndrome. It's part of the syndrome. Doesn't mean you can't lose weight. No. Do you necessarily, could you consider moving on to pharmacotherapy? Absolutely, my friend. Absolutely. I am a bigger fan of Ozempic in the context of, and this is not a brand thing, let's call it GLP-1 agonists, because that's the generic name. I'm a bigger fan of that in combination with metformin for a woman with PCOS, because a percentage of what is probably going on is insulin resistance, and that's what those drugs were made for. So go back and talk to your fertility specialist about that, because there is some good data on that. Great questions, guys. I'm getting all tied up because I'm passionate. Who've we got? Santinus Treasures. Thoughts on double embryo transfer at day 3 if embryo is not making it to day 5? It's definitely a discussion point, 100%. If you have recurrent implantation failure where you have put back 3 or more good quality embryos, so therein lies the issue, are your embryos good quality? Then putting back 2 embryos is going to increase your chances of a positive pregnancy. Putting them back at day 3, I guess, is the old way that we used to do it. And the theory, I guess, is that they do better in than out. It's very lab dependent. It depends on how good your lab is culturing them to day 5. But I think if you've had multiple transfers, it's definitely up for discussion, as long as you understand the risks of doing a double embryo transfer, which include an increased risk of multiple pregnancies and also miscarriage. So have that chat with your fertility specialists. Fabulous. These are great, guys. Hey, one more question and then I'm going to wrap it up because I got school homework to oversee. Any more questions? No more. Return to Zenda. How are you doing, my friend? Hope you're doing okay. Any other questions? I think, look, Casey, Pelvic Health. Kelly, how are you? Thanks for jumping on. Any other questions? These have been some really good ones. I don't think I missed any. Nope. Last minute question. No burning questions. I don't think there is. Well, ladies and gents, if there are any on there, thank you so much for jumping on. I'm going to give you a little heads up that I'm not going to be here next Tuesday. We've got another one. Human growth hormone helpful for egg quality. not in my opinion. But that, again, is up for debate. I think that's a moving beast, but the current evidence on the use of human growth hormone in large-scale randomized controlled trial has not shown that human growth hormone is beneficial. However, could it be limited to certain populations that perhaps are of a certain age, have had a certain number of transfers, perhaps have had proven issues with embryo quality? It's certainly up for discussion with your fertility specialist. Okay, it is considered an adjuvant, but there is not good quality evidence to support its use, and there is actually good quality evidence to suggest that it doesn't actually work, and it's not cheap either. All right, Groovers, have a lovely week. I am off, but yes, next Tuesday I am off to Spain to World Fertility Leaders Conference, all of 48 hours on the ground. But I hope I'm going to learn some great things and meet some fantastic people. So have a wonderful week. I will see you on the other side, wiggle style, and I'll see you next time.